if people think about high blood pressure, you take your blood pressure medication every day. That just means you're dependent on those drugs. You're opioid dependent. It doesn't mean that you're abusing hypertension drugs. It just means you're taking them as prescribed. And that's really what chronic pain is.
Welcome to the second episode of the Saving Dose podcast. Thank you for wherever you are today for tuning in on your favorite podcast platform to listen to the Saving Dose, where we talk about all things addiction recovery. So whether you're a patient or you're a caregiver or you're a nurse or you're a clinician or you're an operator, an executive at a facility or a outpatient treatment, or just somebody who cares about addiction, who has a friend that suffered from addiction. You want to learn about all things about addiction recovery. This is the podcast for you. So my name is William Pedranti. I'm an attorney and biotech entrepreneur. One of the hosts here, we got with us today, Dr. John Su, longtime anesthesiologist and a practitioner in addiction medicine with us. One of our other co-hosts here with us today. And then Kendra Alley, who's a business executive that's lived in the recovery space. She was a nurse working in treatment, helping in recovery, and then was a business executive for many years in addiction recovery. She's the other host. She unfortunately can't be here with us today, so it's just going to be Dr. Sue and I covering a very important topic today, and that is common misconceptions about pain management and opioid use disorder, or what we'll call an abbreviation OUD. You'll hear us use that a lot. But it's essentially opioid use disorder. And we'll dive into a little bit here in just a second. How you doing today, Dr. Sue?
Well, I'm good. Really busy, but I'm really good.
Yeah, I know you are. Well, thank you so much. It's great again for episode 2. I loved our first episode where it was just a launch kickoff with you, me, and Kendra talking about the addiction space, a lot of our backgrounds, what gets us so excited about being in the addiction space and helping with recovery, helping patients and doctors and clinicians and helping recovery. So super excited about episode 2. Love this topic. So important, this topic today, because there is a lot of misconceptions around pain management and OUD. So super excited to talk about that, talk about what opioid use disorder is. Before we even started, though, you and I had a wonderful opportunity last weekend down in San Diego. It was the American Society of Addiction Medicine annual meeting, right? Where thousands of practitioners in the space and executives showed up down in San Diego to talk about addiction recovery. And I tell you, I just got more motivated, right? Down there for 3 days, meeting with people who are living every single day in the addiction recovery space. People I met from California, from Texas, from Florida, North Carolina, Ohio, Alaska. Somebody who was from a tiny little town that I've never heard of between Fairbanks and Anchorage, Alaska, out there with the native community, right? Fighting, alcohol use disorder and opioid use disorder and trying to help save lives. And it's just awesome to see so many people out there committed, right, to trying to help people and help people recover. Just curious about your thoughts about ASAM and some of the takeaways maybe you had from that conference this past weekend.
Wow, that's a tough one because, we're in the fourth decade of the opioid epidemic. That means that we've had 40 years of this. And, it just goes to show you that it's really tough to deal with opioid use disorder. That's a politically correct term for addiction. And really, what addiction is, or opioid use disorder, it involves behavioral components of compulsive use of opioids and loss of control and continued use despite harm. People can be physically dependent without having OUD, but that's really part of the start of the misconceptions of pain and OUD. So, ASAM was great because there's a lot of people that come together, and if we can form a consensus, we can treat a lot more patients and be more successful.
Absolutely, absolutely. No, I agree. It was, again, it's so encouraging to see so many people in the addiction recovery fight, right, to help people that afflicts millions of people, right? I think I was reading some of the statistics coming out of ASAM that talked about 48 million Americans suffer from addiction. 48 million. It's like 1 out of every 7 people has some form of addiction, half of which is alcohol, the other half is drugs, And then a crossover, about 7 million, those 48 million suffer from both. And so we got big challenges ahead. I'm glad that we're doing this. It's great to work with you, Dr. Sue. It's really an honor and a privilege to work with you in addiction recovery. So let's dive right in to our topic today. Again, misconceptions about pain management and opioid use disorder treatment. And so, I'll be asking you, firing you some questions, Dr. Sue, to really dive deep into your decades of experience in this space, treating patients, helping patients. And so we'll start it off by a question I've got. If somebody is prescribed opioids, right? So they're prescribed opioids by a doctor for chronic pain. So they're taking opioids every day to try to treat chronic pain. Does that automatically mean that patient has developed an opioid use disorder?
No, because if people think about high blood pressure, you take your blood pressure medication every day. That just means you're dependent on those drugs. You're opioid dependent. It doesn't mean that you're abusing hypertension drugs. It just means you're taking them as prescribed. And that's really what chronic pain is. Or people with cancer. Let's say people with cancer. They have years of treatment and they've been on opioids for years. And that means that they're opioid dependent because they're tolerant to opioids. You try to stop those opioids, you're really going to harm them because then you have a patient on opioids and you try to stop the opioids. If you don't stop it in a slow fashion, you just stop it and all of a sudden, those patients are going to go into withdrawal. They're going to have cravings, they're going to have withdrawal. And that's when you get that compulsive use. And then you develop opioid use disorder. The diagnosis of opioid dependency and opioid use disorder are totally different. The treatment is totally different.
Yeah.
It's just really, it's really frustrating that as a physician, people just assume if you're taking opioids, you have opioid use disorder. And that's simply not
Yeah.
true.
Well, that's an important point. I'm glad you said that, right? Because there's going to be that stigma around that if somebody's dealing with chronic pain, like you mentioned, cancer pain or low back pain or something they're dealing with every day and they're prescribed opioids, that people look at them and say, well, you must be addicted to opioids. So you talked about dependency and then opioid use disorder. So tell me what that looks like. So if somebody, just so I got clear, if somebody is being prescribed opioids because they've got cancer, they got cancer pain, right? And they're taking an opioid every day to treat that cancer pain. And just like you said, if they're taking it as prescribed for weeks or months or whatever, because they're treating cancer, that is, from your perspective, that's not an opioid use disorder, right?
No,
Yeah.
it's like, it's like eating. Okay. If you don't eat, you're going to be hungry. And that's really we're dependent on food to survive. But what happens if you go to a buffet and you overeat? You're just not going to feel good. And that's what happens with opioid use disorder. You take so many opioids like a buffet and you just don't feel good afterwards. After you eat, you loosen your belt, your pants are too tight. Some people vomit, and that's what happens with withdrawal symptoms. People just don't feel good. They vomit, they have anxiety, headache, heart rate is going fast. It's just not a very comfortable feeling. And the only thing that gets rid of it is another opioid.
Yeah. So it could be where somebody is taking opioids, and like you said, and immediately they get taken off immediate, right? There's not a step down treatment plan, but they get taken off it immediately. That can result in somebody developing opioid use disorder. Is that right?
Yeah, because you have rebound need for the opioid. And when you get rebound need, people have a passion to begin to get opioids, and that's all they think about. They There's a whole downward social economic situation. That's all they do is they think about getting the next high, the next hit of opioid. And they lose their job, they lose their wife, they lose their kid, they become homeless, they become unemployed. It's just a downward spiral, and it's very difficult. And that's the difference between opioid dependency and opioid use disorder because people who have opioid dependency, they may have cancer, but they're living and they get better, meaning that their cancer goes into remission. They're just like you and me. They're talking, but they're on high dose of opioids. I have a person who is on high dose opioids, over 300 milligrams. He's been on it for years and he works. And he's like you and me. He talks, but he takes it as prescribed, doesn't take one pill more, doesn't take one pill less. It's taking me years and years to try to reduce the amount of opioids he takes, but he's not abusing them. If I
Yeah.
stopped his opioids all of a sudden, he's going to go in withdrawal. He may end up in more pain, may end up with more need or cravings of opioids, and he may actually commit suicide. In 2016, when the CDC said that no patient should be on more than 90 MMEs of opioids, there was a concept called pain suicides. People couldn't get opioids because doctors were afraid of prescribing opioids, and people would just commit suicide because they felt no option, no alternative. They were in so much pain that the only thing they saw to end their pain was death.
Gosh, gosh, that's so tragic. So the importance of, like you're saying, somebody's on dealing with chronic pain and they're on an opioid treatment program. They have that dependency because they need it to treat the pain. But as your example, somebody may get over cancer and that pain is now gone, and they'll work with a physician like you to titrate themselves off those opioids and reduce that dependency, right?
Yes.
Yeah. Okay. Wonderful. That's such great information. Thank you. That kind of differentiate between dependency when somebody's getting opioids and taking their should, and then when somebody develops truly an opioid use disorder, right? So I know in your toolkit to treat somebody who's dealing with opioid use disorder, you're using medications like buprenorphine or methadone for opioid treatment. Is that just substituting one addiction for another when you do that for opioid use treatment or no?
Well, that's really a common myth because if you're opioid use disorder, you're taking medications that above and beyond what I prescribe. If you're taking buprenorphine or buprenorphine and Narcan, which is called Suboxone, and methadone, you're taking them as prescribed, and it actually stabilizes the brain chemistry, so you don't have those cravings, you don't have those withdrawal, and people can function normally with like just as you and I are talking on buprenorphine or methadone, and it saves lives. I don't understand. We can reduce the overdose death rate by greater than 50%, but only 25% of people get these life-saving medications. We really need to increase people with treatment because you mentioned earlier 48 million people need treatment. Well, you know, I hate to bring this up, but we're in a war situation at this time. And in the VA system, there's 44 veterans die a day from suicide and opioid use disorder overdoses because they can't get treatment. There's 408 clinics in the VA system that treat 6,500 patients, but there's just too many patients. And when you have that situation, it's very disappointing for me because I can't treat as many as I can. There's only 24 hours in a day. There's only one of me. There should be more of me to treat more of these patients.
Right. Well, thank you for saying that. It's John, it's almost hard to even get your head around those types of numbers you just mentioned, right? In our the number of addiction veterans community, the number of overdose and suicides among veterans because of issues like this, it's just truly tragic. And I agree, sounds like what you're saying. These medications work, right? Buprenorphine and methadone and other drugs, they work at helping people deal with their addiction, right? But it sounds like getting access to these medications is a real challenge for a lot of people. Yeah.
It is
Yeah.
because, there's few doctors want to treat these patients because many of them have lost their jobs. So many of them are on Medicaid or in California, Medi-Cal, and they tend to take more time. So it ruins um, your flow in your office. So many of these patients are difficult. They're more difficult, but they're difficult for a reason because I'm treating two patients in one. I'm treating the patient's mind because they have a mental addiction or a mental need to take these drugs, and they have a physical need to take these drugs. So I have to assess their mental needs and their physical needs. Opioid use disorder is a chronic medical condition, just like high blood pressure. We treat blood pressure with medications, and we don't treat opioid use disorder with medications as we should because we can really reduce overdose deaths with it. Like I said, 50% reduction in overdose deaths, but only 25% medications or 25% get these medications. I really hope I can really encourage people to get treatment because it can be life saving.
Yeah, I love how you said that thinking of this as a chronic disease, right? A chronic disease that we're trying to treat. So important, right? It's not a, hey, go to a clinic for a month and you're going to be good to go, right? Maybe that works for some, but really thinking about, like you said, for chronic disease, and it highlights a situation I was just thinking recent. I think I shared with you offline was a friend of mine's brother, right? And I'm 53. He's a little bit older than me. He's 57, 58. And he literally a, a week ago checked himself into a residential treatment facility. And he's been dealing with addiction for over 30 years. 30 years. He's been from when it was over 30 years ago where he first got addicted to an opioid. And here he is 30 years later. And in fact, he actually didn't start taking opioids again, but he knows after 30 years of dealing with this chronic disease what signs internally for him look like where he becomes at risk for relapsing back. So he voluntarily checked himself into a residential facility just to make sure he doesn't. And it's just true. It's like 30 years he's been dealing with this. And then every day that goes by, he doesn't deal with it. And so I'm glad you said that because it's really is a chronic disease and has to be thought about like that, right? And I agree with you, getting access to these medications so important because they work. And I love what you said about the importance of these medications. It's not substitute addiction for one or the other. So it's that stigma we've got to get away from. That if somebody's getting methadone, if somebody's getting Suboxone, got to get away from that stick. Well, they're an addict, right? They're just they're taking methadone, so they're an addict. Got to get away from that and say, no, this person has a chronic disease and condition they're dealing with, and they're dealing with it the right way to make sure that they don't relapse. So I love what you said. So important to get that message out, John. Another question I've got too is so somebody you start treating somebody, right? That's on now opioid use disorder treatment. So they're getting methadone or buprenorphine or some other medication for it. Can they still receive opioids for acute or chronic pain management?
They should.
Hmm.
Because if you're on these drugs, that just means that your brain cells are being stabilized for the mu receptor so that you don't have the cravings and the withdrawals as much. But if you have pain, there should be no reason for you to stop these drugs. In fact, you should take the correct dose for pain. As an anesthesiologist, if a patient comes in with Suboxone or methadone, I don't stop it. I actually keep it going and I give them medications for the pain. These two drugs are actually opioids, and they can actually treat some of the pain. I may give them the same dose, which makes many other doctors nervous. But, you know, if you have experience with these kind of patients, you become familiar with it. And that's very, very important. You need to be, as a physician, you need to be familiar with these patients because not all doctors are familiar with opioid use disorder and how to treat these patients for surgery or acute pain. The more you leave a patient with acute pain in pain, the more they're going to crave opioids and the higher the chance they're going to relapse.
Yeah, that's awesome. That last nugget's a good one. God, there's several things you said there I want to unpack a little bit that I think were so important. I love that last thing that you just said, right? Don't forget to, you got to adequately treat that acute pain, right? Because that could morph into something a lot more dangerous. So right now, if somebody's on, going back to what you said, one of the things you said at the beginning, so somebody's on, could be on buprenorphine or methadone, so they're on an opioid for addiction, opioid use disorder, right? They may be getting adequate pain relief to treat some painful condition they've got. Is that right?
Sometimes, but
Yeah.
it's not really used to treat pain normally because the the action needs the pain analgesic part of it only lasts for 6 to 8 hours. But the stabilization of the brain chemistry lasts a lot longer. So if somebody is on Suboxone or methadone, they can actually be taking other opioids for acute pain for a short that these medications for acute pain don't last as long, 4 to 6 hours or 4 to 8 hours, and they can take those other pain medications. You just have to have a pain doctor who knows addiction medicine as well.
I love that you said that last point, 'cause that's the point I was gonna come right back to. So just to recap what you said, so somebody could be treating opioid use disorder, they're getting Suboxone or methadone. They may have a surgery or something where they need additional opioids, right, to treat an acute pain, right? And that's okay. That's a very important point that you made. But that last piece is so important too, right? Just what you said is you need to make sure you're talking to a physician like yourself that understands pain management and addiction medicine, it sounds like, right? Somebody who's skilled and seen these types of patients, right? To really make sure somebody is getting the right type of therapy, what they're dealing with. Sounds like, right?
Yeah, that's right. Absolutely. Before surgery, most doctors will tell you, most anesthesiologists will tell you, don't eat or drink anything before surgery. And some are not so careful to tell you to ask you what medications you're taking. So some doctors will tell you not to take your diabetic pills or hypertensive pills, high blood pressure pills, or your pain management pills. And if that happens, you get a rebound diabetic increase in your sugar. You get a rebound high blood pressure because you didn't take your medications, obviously. And you get a rebound craving for opioids or withdrawal symptoms because you haven't taken your OUD medications. And that means the anesthesiologist is not going to give you a higher dose to cover that opioid use disorder medication deficit. And you're going to wake up in extreme pain and you're going to be dope sick and you're going to be highly nauseated.
Mhm.
Many doctors, there's about 5,000 opioid use disorder doctors in the United States. There's close to 1 million doctors in the United States. And not everyone understands opioid use disorder yet. There's no consensus for treatment. And that's probably why we have the opioid epidemic in its fourth decade.
That's crazy. A couple things you said there. First of all, you mentioned Dope Sick, right? Which I just have to say as a side note. Have you seen that? I can't remember if it was on Netflix or HBO, whatever it is. Have you seen that
Yeah.
Dope Sick? Well, I think it's
Yeah.
Michael
And
Keaton. It's
yeah,
good. It
it's
is.
true. It's
It
really
is.
true.
Yeah, it's well done it's just shocking when you watch it, right? Michael Keaton, what he goes through, right? He's a pain management doc, right? He gets hooked. I don't want to spoil it if you haven't seen it, but if you haven't seen it, go see it because it does a great job at highlighting what it. And I think about you when I thought about the movie because when you tell your story about patients in the parking lot and things like that. I always think about that show Dope Sick. So if you haven't seen it, go out and see it. It's really, really good. But so just so I want to harp on one last point on what you said because I thought was so important is really this idea of you're treating opioid use disorder, but if somebody has pain, right, and so they need to treat that as well, and so because you worry about, I think you kind of said that if somebody is not getting their pain treated too, right, it sounds like they're potential at risk for relapse if that pain is not be treating. Is that right?
Absolutely. Well, let me ask you a question. If you have acute pain and I prescribed opioids to you, hypothetically, right? There's a hypothetical situation, and you begin to take opioids, and then your pain doesn't go away, and I stop giving you opioids. What medication are you going to go to relieve your pain? Tylenol doesn't work. Motrin doesn't work. There's something called fentanyl that's sold everywhere in the United States.
That's right.
A lot of people who can't get pain relief go to illicit fentanyl.
Yep. Yep, and why we have so many overdose deaths because of fentanyl, right? It's so tragic. So, so tragic.
88% of opioid overdoses are from illicit fentanyl. 12% are from prescription medications like prescription opioids. And that presents another problem because when you try to save these patients with Narcan or what's called naloxone, many of these patients require 2, 3, 4 doses, and you have Narcan dosing ambiguity. And really, it's very difficult to reverse the opioid-induced respiratory depression from illicit fentanyl because the doses are so high.
It's just incredible. Yeah, so dangerous. A lot of times people don't even know, like, all these drugs are laced with fentanyl and things like that, right? People don't even know that they're taking fentanyl. So, so deadly, so deadly. So, I want to thank you so much for this. This is such good stuff, John. But just shift a little bit. A different type of question is, I think one of the challenges people hear because there's so much stigma around opioids and people that get hooked, everybody's afraid to get hooked, right? They're afraid, oh my gosh, if I take this opioid that my doctor wrote me after my dental surgery or something like that, I'm worried about getting hooked. And so I kind of wanted you to address that question is, does everyone that's prescribed opioids gonna become addicted? So the doctor gives you something and I take it for a week because I'm in terrible pain. Is it, oh, I'm in trouble because I'm gonna get addicted to this and I'm not gonna be able to get off it? Or is it more rare? What do you see in terms of opioids if people use them appropriately, right? What are you seeing in terms of that?
Well, let's just look at the numbers first. There's about 137 million prescription of opioids prescribed by doctors per year, and we have 12,000 people overdose and dying.
Wow.
The percentage is very, very low of people who are overdose and dying on prescription opioids. It's close to 1%, right? But the issue there is that if you are taking opioids for 7 days and you end up taking it for more than 7 days, let's say 60 days, the chance of becoming addicted or opioid dependent is higher. At the end of 30 days, the chance of opioid abuse, or 60 days, the chance of opioid use disorder climbs. If you're on long-term opioids, that doesn't mean you're addicted yet, but the chance of opioid use disorder goes up. But also at the same time, the chances of opioid dependency go up as well. And the problem is, if you're opioid dependent, if you've been taking opioids for 6 months, it's going to take a year for you to get off of those opioids because you have to reduce it so slowly.
Wow.
If you reduce it too quickly, these patients they go in. You can force someone who's opioid dependent into opioid use disorder because the treatment of opioid dependency is to treat the side effects because they need the opioid. As long as they're taking it as prescribed, they're not abusing it. The problem with opioid use disorder is they're not taking it as prescribed, they're taking other drugs. 70% of 70% of overdoses are polypharmacy, meaning
Uh,
people take a lot of opioids. And in those situations, you have to treat it differently.
yeah.
Narcan, which is just strictly for opioids, doesn't work with the other drugs that patients may take. Patients may take xylazine or tranq or dexamethasone or benzodiazepines. Those drugs require a different antidote. That's why many patients who overdose, you give them a dose of Narcan, it doesn't work because it's not the right drug that it's trying to reverse.
Yeah. Interesting. Couple of takeaways there I take. Because like I said, a lot of people fear opioids because of what's going on in the crisis that we're dealing with. But, what you're clearly saying is, when opioids are prescribed appropriately, right, in a situation, and patients take that compliantly. So they follow the prescription program the doctor has, we see, the chances of getting hooked or addicted are very low, right? It sounds like in many cases, which is great. But that also goes to the issue you said several times before. You want to make sure you're getting those scripts from doctors who understand, right? Pain management, understand how to prescribe appropriately, right? And for pain and stuff like that.
Yeah, you know what's very, very interesting is that some patients fear opioids. We had an opium wars in the 1830s and 1850s where Britain put the opiums in China, and it caused many people to have opioid use disorder. Physicians are afraid to prescribe opioids as well because in the last decade, there's been a 44% drop in opioid prescriptions for acute pain and incredibly a 40% drop of opioids for terminal cancer pain. That means that people are left in pain for acute pain and for terminal cancer pain. Are we really leaving patients who are dying in pain? I really
Yeah.
hope not.
Yeah. I don't
I
be
really
either.
hope not.
Exactly. Yeah. No, and I think I said this crisis has scared a lot of people, scared a lot of docs from wanting to do that. And you're exactly right. So I think that's so important. We're just about out of time, so we just got one more question here. I want to kind of be the last question. We can kind of wrap this up here too. Is when thinking about treating pain management, just like we talk about, somebody's got pain, want to make sure that they're appropriately being treated with opioids in the appropriate circumstances. People are taking compliantly taking it all so to ask this next question is, are all pain management approaches primarily about opioids, or are there other treatment options if for some reason opioids are not appropriate or somebody's looking for something other than opioids? Are there other effective non-opioid treatments for pain?
Well, let me start off by saying opioid use disorder is a symptom of something else. Pain is the etiology, but for patients who have pain, there are other drugs that can reduce pain. This is a funny story. And um, when I first started with the opioid epidemic in 1999, I was pushing a concept called multimodal pain therapy. And I was using other types of drugs to reduce other reasons that pain can be magnified. So I would use an anti seizure drug to reduce conductive impulses getting into the brain to have the brain perceive that as pain. Then I would use a strong antidepressant to reduce the concept or perception of the mind to pain. Then I would use something to reduce nausea, which, if you're nauseated and you try to throw up, it's going to increase your pain. I would try to reduce anxiety by giving something to reduce anxiety as well. And to something else to reduce pain, there's a lot of different types of drugs to reduce pain. One of the funniest things that happened to me was that, medicine is a very conservative practice. If you do something new, people just think you're crazy. And people will just say the funniest things.
Yeah.
People think of acupuncture. There's other
Yeah.
physical things that can do it. Acupuncture can reduce pain. And I was doing pain blocks with the ultrasound before a lot of my colleagues are doing it. And people thought I was doing acupuncture on my patients and asked me if I was bringing something from China to the US to treat American patients. I said, no, this is something that is up to date. We're doing multimodal pain therapy where we're trying to reduce opioid uses, not get rid of, but reduce it. 30 years down the road, Medicare has now said that they are making sure they will not penalize doctors who use multimodal pain therapy. And, it just seems like I'm kind of ahead of my time. I'm not bragging, but I'm just ahead of my time. And it's really for a good reason. I really care about my patients and I really try to do my best.
Yeah, I know you do. I know you do. So thank you so much. We're out of time, but I wish we had more time. This is such a great topic. I've learned so much. And on that last point about, I know we just dipped our toe into talking about other non-opioid ways to treat pain. And maybe we could do another podcast in the future just on that topic, because I'm sure you could get a ton of great information from you, John, in a 30-minute segment about all the other alternative approaches that you've used in your multimodal treatment programs over the last several decades. But I've learned a ton. Thank you so much, John. This has been great for me. I've learned a ton despite having built a pain management company in the past. In this space, I still learned a ton. I hope all of our listeners out there have learned a lot as well. If you like this podcast, please like it on your favorite platform. If you want to leave comments, please do that. We'll do our best to get to those. You could certainly reach out to us at our website we're building if you have any questions, but we really appreciate you listening. If you have any future ideas or things you'd love for us to talk about on this podcast, please submit it, because this, again, is all about all things addiction recovery. And so thank you so much. I appreciate you guys spending time with us today. Thank you, Dr. Sue. I really enjoyed it. And we'll see you guys in 2 weeks next on the Saving Dose podcast.